let's get into it. Now, I would like you to pause this video and check in the description. There's a quiz I put up. I want you to try it before you watch this video and try to fill in those 10 questions. Or there may be a bit more if depending. Check on those questions, try to fill each one of them, and then play this video and we see what's going to happen. So when you look at pertussis or whooping cough, it is going to be caused by the organism that is called Bordetella pertussis, and this is a gram-negative coccobacillus. It is an obligate human pathogen. This means there's no animal reservoir. It's only going to be found in humans. Then we have another one known as the Bordetella pertussis, which has been found to cause a milder illness, and it is not covered by the vaccine that we use for vaccinating against pertussis. So one of the important things you have to know is the toxins that are produced by this Bordetella. The organism itself is not too much responsible for the effects, but the toxin is what is going to cause most of that systemic illness. So pertussis toxin, it's going to be one of those toxins that are important, and it's going to cause lymphocytosis. That's why you see most of the time in people who have pertussis, we have a lymphocytosis rather than a an increase in the neutrophils. Then we have, it's also important for immune suppression. It's the most important toxin. Then we have the tracheocytotoxin, which is going to destroy the ciliated epithelium. And when the epithelium is destroyed, the cilia are supposed to continuously beat to push the mucus out of the trachea. This is going to happen, and you shall have a mucostasis. And when you have a mucostasis, it's going to cause the paroxysms of cough. So the cough is going to cease for a moment. Because of this mucus accumulating, the cough begins. Then you eliminate that mucus, the cough stops, mucus accumulates again, and you get another paroxysm. Then you have the adenylate cyclase toxin, and this is going to kill the phagocytes and infects ciliated epithelium only, and it will never enter into the bloodstream. So when you look at the stages of the disease, it's going to occur in about 2 stages. We're going to have the Catarrhal stage, and that's going to take 1 to 2 weeks. And this was going to look like a common cold, like if someone has a simple flu. And the diagnosis here is most of the time going to be missed. Then the paroxysms of the coughing are going to begin. That is 2 to 6 weeks, where we have the coughing fits or the coughing episodes. And it's a respiratory whoop, where someone tries to, they cough too much, and during the coughing, they're not actually breathing, or they have some cessation of breathing. Then all of a sudden, they're going to take this deep breath. It's going to sound like a whoop. But sometimes it's associated with post-tussive vomiting. This is especially in older children. They'll have a post-tussive vomiting, and while between episodes, they have no fever. Then we have the convalescent stage, and this is going to now be in weeks to months, where someone continues to have this mild cough and then it's going to take about some next 2 months. And for that reason, it was known as the 100-day cough in China. It is Bordetella pertussis or whooping cough. So look at the age variations. In infants, we may not have a whoop, we may have an apnea, and the highest mortality is in the kids that are less than 3 nights. In adults or adolescents, we have a prolonged cough, you have no whoop. And most of the time, it's going to be misdiagnosed that bronchitis, and this is done. That is why we have the humans being the main users, because if you have a wrong diagnosis, there is going to be a provision of the right treatment. So when you look at the diagnosis, here are some important facts that you have to know about the diagnosis of pertussis. So the CBC is going to cause absolute lymphocytosis. That's what we're going to see. And they're going to be, the lymphocytes are going to be on normal morphology and not atypical, because the pertussis toxin blocks lymphocyte coming. Then WC count is going to increase, and in infants, if we have a WC count that is greater than 100,000, then it's going to be a poor prognosis factor, because that means you're going to have a leukostasis. Then when you do the culture of a nasopharyngeal swab on the Bordet Gengu or the Reganio, these are the culture medians, you're going to see that we have this kind of picture later on. And this is best when we do this in the Catarrhal stage. The Catarrhal stage. Then PCR is the most sensitive overall, but culture is the gold standard, and it is best started after It is best after antibiotics are started. Then we have a serological tests where we do the anti-pertussis toxin IgG, and it is useful in the late or in the convalescent disease, unless if someone has been recently vaccinated. So we have some of the important differentials that you have to know. One of them is viral group, and group is characterized by a backing cough, and this is going to be an examination confuser. You find that they bring a backing cough or they can bring this whooping cough. Most of the time, people make a mistake of mistaking one for the other. So in viral group, you have the backing cough, a stridor, and the young toddlers, and there is not post-tussive vomit. And in foreign bed aspiration, it's going to be of sudden onset. There's no that Catarrhal stage or lepidral. You will have a localized bleeds and no prodromius. Then RSV or bronchiolitis, you're going to have a wheeze. It's going to be in younger infants and a different CBC picture altogether. Then mycoplasma pneumonia is going to cause an abnormal kind of anemia. It's going to be of gradual onset. It's going to be in older children, atypical lymphocytosis, atypical lymphocytes, elevated cold agglutinins. Then chlamydia trachomatis is going to be in neonates. We are going to have a staccato cough. We're going to have conjunctivitis and dyspnea. So some of the complications of pertussis in infants, apnea is going to be common, hypoxia, and this can even cause encephalopathy later on because the brain is not on oxygen. Then secondary pneumonia is going to be one of the highest causes of mortality, and especially in these children. The pulmonary hypertension is also going to be commonly seen. Then we rib fracture, then seizures, encephalopathy, and death. In other patients, we can have rib fractures due to the forceful coughing. We can have pneumothorax. We can have urinary incontinence, and then we can have syncope. So the treatment, macrolides are going to be first line, and the exam trick is that they're going to bring a list of macrolides in your MCQs: azithromycin, clarithromycin, erythromycin. Always choose azithromycin is the one that is preferred, especially if the child given it below 1 year. This is because clarithromycin and erythromycin have been associated with infantile hypertrophic pyloric stenosis, and this is commonly tested. And the second line for treatment is going to be trimethoprim, sulfamethoxazole, and it's going to be in those who cannot tolerate the macrolides. So antibiotics are going to shorten infectivity, but they have little effect or effect on the symptoms if given in the paroxysmal stage. So they may not be able actually to stop the amount of coughing. Again, remember, the effects are going to be caused by the toxins more than caused by the Bordetella pertussis itself. And so ODF care is going to be very key. If they are vomiting, admit them right away. They're having a post-tussive vomiting, they're having other things. We have looked at the complications. You want to give them the antibiotics. They have a secondary pneumonia. Please make sure that you look at all those things. So the prevention or the vaccination, we use the DTaP vaccine, and it is given to children, and the schedule is 2 at 4 at 6 months and at 15 to 18 months. That's especially for children who are less than 7 years. Now above 7 years, the DTaP is not recommended, and the TDAP is the one that's going to be given, and it has a lower dose, and it's a one-time booster given at 11 to 12 years. So the recommendation is that all pregnant women in the third trimester, allowed 27 for 6 weeks, are given this TDAP vaccine, and this is thought of to pass on the passive immunity to the newborn child so that they do not get this disease. Then close contacts of newborns or cocooning is another strategy, and the immunity that you get from vaccine is going to wane after 5 to 10 years, and this is going to explain why sometimes you have adult breakouts. So the key important exam points you have to know is that we have lymphocytosis and CBC in a coughing child, think pertussis, post-tussive MSS, and an inspiratory hope is classic. Infants may present with apnea instead of a hoop. Azithromycin is the drug of choice, and it is most infectious in the Catarrhal stage, even before the diagnosis is usually made, and TDAP is going to be given in every pregnancy in the third trimester. So we have come to the end of this video. I hope you have covered a lot of information about this. If you did not do the quiz at the beginning of this video, please do that quiz and see if you can pass through those questions easily. My name is Benjamin. This is Mid1 Pager. Let's meet in the next one.